I will call the meeting of the Potter Valley Healthcare District Hospital Corporation regular session into order at 5:28 p.m. Rosie, can you please give us a roll call?
Yes. Director Gallagher.
Here.
Director Hennessel.
Here.
Director Cox.
Here.
Chair Davis.
Here. So I am going to read up a reminder for all of us attending either in person or via Zoom. So as you know, these meetings are publicly broadcast via Zoom. Even in the case that the public is not physically present, please consider that participants may be virtual and the meeting is recorded and posted for public viewing. I'm gonna quickly ask if we have anything to report from closed session, and I don't believe we do. Nothing to report from closed session, so I'll move on to agenda modification consideration from staff. Anything? No. So now we'll move on to items for public comment on items that are not on the hospital corporation agenda. Rosie, anyone looking to comment?
No hands raised on mine.
Okay, anyone looking to comment on items that are not on our agenda for tonight? Seeing none, I'm going to ask for comments from our board members. Any comments from our board members?
I have one comment.
Okay.
So I believe that even though Sherry Stout-Torres is not able to be here tonight, I believe that this is officially our last board meeting with her as our interim chief nurse officer. So I just wanted to publicly acknowledge her. She, 2.5 years is a long time to be interim. And so she certainly, we never looked at her as interim. She has been such an integral part of the team through many ups and downs. And I have always so appreciated her contribution and her even style and sort of problem-solving attitude. So I just wanted to say thank you publicly to Sherry and to the team, and I'm so grateful for her leadership.
Fantastic. Thank you.
Mhm.
Marcus or Dr. Gallagher, any comments? No.
Ditto. This session. Thank you for sharing.
Thank you. Before we move on into the consent agenda, we'll just give, I see some new people in attendance that have not been with us before. So I'll just give an announcement that there is one item in our agenda for the Potter Valley Healthcare District. And so it might be a little different than a typical public meeting, but we will finish this agenda and then, or finish this meeting and then recess and go back into another meeting, which will have the item which I'm sure people are wanting to comment on. So bear with us as we make our way through two meeting agendas. So Rosie, as we go into the consent agenda, can you read off the items on the consent agenda for us?
The first item is the minute approval for March 27th, 2024. The second item is the policies and policy summary approval of April 2024. The third item is the appointment of the Potter Valley Healthcare District Hospital Corporation Finance Committee member. The fourth item is the agreement extension for chemistry laboratory reagents. And the fifth and final item is the Potter Valley Healthcare District debt policy.
So before we go out for any public comment, any questions, clarified questions from the board? Go ahead, Marcus.
Yeah, question on item number 4, our agreement for extension. Two general questions. One, I have a minimum purchase that I assume is a good floor that we don't normally have a gap where we're required to make minimum purchases of items. And so I guess my question is make sure that that's a good floor, that we're not going for that, having to give the vendor additional months that meet our minimum purchase. And that it makes mention of we're leasing equipment, and again, our presumed staff looked at it, and if there's an opportunity for acquiring equipment versus a lease, sure, that's something that we look at. So I guess I'm just commenting kind of captain obvious statements that I trust the team, know the team, or just not. So ask those questions or ask that first question, just make a statement about it. Always look for opportunity if there's a reason to purchase, that makes more sense than these things, right?
Anything else? Any other questions? No? So I'm gonna open it up for public comment on the consent agenda items on those, 5 items that Rosie read off. Rosie, anyone online?
No hands raised online.
Hands raised online. Anyone in person that would like to make a comment on the consent agenda? No? Okay, so I'll bring it back to us. Any final, comments or staff about any of those 5 items before we go to a vote?
I'll move approval of consent.
Second.
Thank you. I have Pimentel and Gallagher. I'll take roll. Director Gallagher,
Yeah.
Director Pimentel,
Yeah.
Director Cox,
Yes,
Chair Nino.
Yes. All right, thank you. That passes unanimously. We're gonna move on to item number 6, and this is our discussion items. This is the Medical Executive Committee report for April 2024. The recommendation is to pass a motion approving 1, the Medical Executive Committee report, and 2, the Quality and Patient Safety Council report for both of them for April 2024. Any questions for staff about this before we go out for public comment on this? Seeing none, I'll go out to public comment. Anyone with their hand raised online? Rosie?
No online.
No hand raised. Anyone in person? No? Okay, any final comments for staff before we go for a vote? No? Yeah.
Sorry. Probably it's done with the email in the PowerPoint presentation on the slide. I really appreciate it. It's good information for the board to see all of our quality improvements and the standards and what we're trying to achieve. I appreciate all that information. This is down the weeds of it uses references to PVHCDHC or Carlisle Healthcare District Hospital Corporation acronym. And I'd love to see us to start using terms something kind of hospital versus district instead of those acronyms. Will really orientate people when they're seeing that as they're thinking of the hospital versus bigger district. This is just in my weeds.
Noted. Okay. So no other comments. Rosie, can you poll the board for a vote on item number 6?
we have,
Oh, we have,
I'll move to approve the MEC report as presented, and also say thank you to Dr. O'Grady for stepping in as vice chair and then assuming role of chief of staff.
do we have a second? Second. Thank you.
Thank you. I have Cox and Gallagher. And I'll take the roll. Director Gallagher,
Yes.
Director Pimentel,
Yeah.
Director Cox,
Yes,
Chair Nino.
Yes. Passes unanimously. We're going to move on to item number 7. That is the CEO report. Take it away, Steve.
All right, thank you very much.
Sorry, one.
Well, thank you, Chair Nunez. It is an honor as always to present the performance so far for the first through the first 3 months. So as our April report has data through March, I will be able to take you through our dashboard. A reminder on our color coding for our dashboard. Red is not where we want to be yet. White is kind of hitting our baseline target. Green is hitting our target performance for the year. And blue is kind of that stretch goal or that best practice. And so our overall dashboard right now, we've got 2 items in the red, 3 items in the white, and 1 in the green. Don't worry if you can't read that, because I'm going to zoom in on each quadrant. Remember that the quadrants are based on our strategic plan and the strategic priorities that were outlined in that strategic plan. So the top left quadrant is our quality and patient experience. So for the 12 months from April of last year through March of this year, we're at 67.4% of our patients have given us a rating of a 9 or a 10 on a scale from 0 to 10, where they're asked to rate the hospital. That's the 40th percentile nationally. Our goal, our baseline goal is to get to the 50th percentile, which would be 70% of patients, giving us a 9 or a 10. That number has been fluctuating the last 6 months. We're very close to that 50th percentile. And so we're hopeful that this is going to come, continue to trend upwards. And we have a number of different activities in place that are being worked on in both ancillary and nursing areas to address that and continue to make that better. For the quality of patient care, we're counting our hospital-acquired conditions, and we've had 21 of these in the rolling 12 months. So again, last April through this March. This is an aggregate of all of the hospital-acquired pressure ulcers, falls with injury, catheter-associated UTIs, central line-associated bloodstream infections, surgical site infections, and C. diff infections. A number of those are at 0, but a few of those are not. On the February dashboard that we saw last month, we were at 26, and so this month we're down to 21. If we get to 16 or fewer, we'll hit our goal for the year, which would be a 50% reduction. So we are on our way and continuing to make strides there. Our main, and Tracy will do a quarterly update for the board next month, which will drill down further on the actions that we're taking in the areas where we have some opportunity. Drilling down a little bit more on patient experience, this is the monthly trend. So you can see it's up and down, but the last, 3 of the last 5 months have been at the baseline or better. We get about 30 or so responses each month. The N for each month is on the row on the very bottom there. 18 so far for patients who were here in February. Haven't received any surveys back yet, at least when I had pulled this a few days ago. For patients who are here in March. When we do, those will get added to this. We have 2 new surveys now available. So that one that we have on the dashboard that we'll continue to look at every single month is for our inpatients. Those are our inpatients who are discharged home. We have 2 more that Press Ganey is surveying patients for us, and one is for patients in our emergency department who come into our emergency department and then go home. And the other is for patients who come here for ambulatory surgery and then go home. And so we're starting to get these data. So we've had 351 surveys responded or come back so far for our emergency department patients. 60.7% have rated us a 9 or a 10, and that's the 32nd percentile nationally, so a little bit lower than our inpatient ratings. Ambulatory surgery, similar question, rate the facility on a scale from 0 to 10. We've had 78 surveys back so far. A higher percentage of patients have given us a 9 or a 10, but that's a much lower percentile ranking. This is a really, really difficult database, the ambulatory surgery one, because it includes outpatient surgery centers where that's all that they do, right? They are very efficient with it and they do it, it's very streamlined, and it's really, that's their entire business. And so we're in a database with those folks. So you need to get to 90% or better of patients giving you that rating to really start to move up their percentile ranks. So it's really great that we're able to look at this now. We do have the ability to look at different types of benchmarking categories, so we can look at different size hospitals and things like that to try to give ourselves a little bit more like to like, but just looking at it on a strict, all facilities across the country, how do we compare? That's where we are right now. So just putting out the reality there. And as we move on to I'll talk about linked metrics as we get later in the presentation and show you some of the things that, we'll be able to put some action plans around some of these specifics. A drill down on our hospital acquired conditions. So these are the numbers month to month of each of the different categories. So you can see for CLABSI, CLABSI is central line associated bloodstream infections, CODI is catheter associated urinary tract infections, and SSI is surgical site infections. We've had 0 of all 3 of those categories for the year to date. And actually haven't had any of those three since we had a couple surgical site infections last June, so that's really great. But the other categories, the falls with injury, the hospital-acquired pressure ulcers, and the C. diff, we've had a couple of each of those so far this year, and so we have, we're working on action plans in each of those areas. So we are at 21 for the rolling 12 months and at 8 year to date. On the clinical services and access quadrant, we're white, which is at baseline for patients served. Right now, the patient served data is counting cardiac cath lab, which is still 0 because we haven't got the approval from the state to open that yet, but it will include those patients. So right now it's ambulatory surgery, special procedures, and outpatient radiology. We got a really good question from a staff member, like, why isn't wound care included in this? We were like, we all looked at each other, we were like, that's a really good question, we're gonna have that. So we're gonna put wound care and outpatient rehab into this metric. Going forward, these are our patients who can choose where they go, right? They can choose to come here, they can choose to go somewhere else for an outpatient procedure or treatment. And so we want to count all of those. We want to serve as many of the residents of the Pajaro Valley as we can who want to come here. So starting with the April dashboard, you'll see this number and the goals change a little bit to see where we're at with all of those categories included. And our other access metric is our percentage of patients transferred from our hospital to another facility from the emergency department. So this is a percentage of the ED patients. And we're green as we are right at the target goal for the year, which is an 8% reduction from last year. Last year, we were at 2.5%, and this year so far we're at 2.3%. So trying to take care of more people here and not have to transfer as many patients out. On the talents and culture quadrant, we improved on our retention rate from the February dashboard to the March dashboard. So we're at 78% retention, which is better than our 2023 performance of 76%. So it's quite at baseline. And for our culture of safety and employee engagement and medical staff engagement survey, that survey is now completed. We had 61% participation. So not bad for our first time doing this. It's definitely a statistically relevant sample that we'll get once we get the results back. The results of this are actually sitting in my email. They actually came in today. So at the May meeting, we'll definitely be able to do a high level overview of some of those results. And hopefully I'll be able to break it down by physicians and staff and all of that. So we can kind of see where we're at there. And I'll have the opportunity to work with our new chief of staff and vice chief of staff on action planning for our medical staff engagement and culture, and all of our managers and directors will have action plans around their results as well. And on employee retention and our culture of safety, we are introducing our Blue Star Awards. So we had for a number of years the Daisy Award, which many are familiar with in other hospitals. That is a nursing focused award. And so we didn't have for quite a long time a non-nursing employee recognition program. And so I challenged the team, like, what can we do? What can we come up with? Is there something else out there like Daisy that's for non-nurses? And for all the other staff and team members. And so they have decided to step away from the Daisy Award and create the Blue Star Award. So this is being kicked off this week. Literally, we've already received more than a half dozen nominations for this just in the first 3 days that we've announced it. So there will be 2 recipients each quarter, one in the patient and family advocate category and one in the team player category. Any of those can be nurses or non-nurses, either one of those. Staff, patients, and public can nominate. We've had at least 1 patient nomination already, which is cool. And we're going to award the first 2 during Hospital Week. Hospital Week is the week of May 13th. And so I think on Monday or Tuesday, we're going to be out in the courtyard and we'll give out the first 2 Blue Star Awards with some nice certificates and public recognition. Put them on social media unless they really, really don't want to and stuff like that. So we're really looking forward to this. Sherry Torres and team have done a really nice job. Jen's been on that team, thank you. Nancy, have put all this together, and so we're really looking forward to getting some staff recognition and getting some good positive vibes up there. Financial sustainability is the fourth and final quadrant. We are just read by about $3,000, about $3,500. Julie will dive into that a little bit more and where we're at. So just about a $54,000 net operating income loss so far for the first 3 months of the year. I mentioned earlier the term linked metrics. So this is one of our conference rooms in the hospital. And we have embarked on this. We've had one session so far. Up on the wall are data, right? So we're making this visible. Along the left side, it says CEO, and it's got 4 of the key metrics that are on the dashboard. And then as you move left to right, you've got the different senior leaders on the senior leadership team. And each of them has a driver within each of those categories. So if the top left one is hospital acquired conditions that we talked about earlier, each senior leader has a driver that if they're meeting their drivers with their teams, and each of the senior leaders is meeting their drivers, then we believe that that will all add up to the hospital meeting its goals for the year. And eventually, as we continue to build this out, each of the senior leaders will have their own board that looks like this, where each of their team members will have all of their drivers. So if all of Matco's people hit their drivers, then Matco will make his driver, and then that will help the hospital hit its overall goal. And eventually, you roll that down to the staff, and every staff member can speak to, here's what I do each and every day. And that helps my department make its driver, and that helps the hospital hit its goal for hospital acquired conditions, for patient experience, whatever it might be. So this is the first step in that. This is the senior leadership team, and we'll continue to roll this along. And you can see on the right there, we've got our primers for our questions that we ask ourselves. You know, what's the driver? What's the goal for it? Where are you right now? What's the gap? And what's the plan if there is a gap to get to green, to get your metric to green so that the hospital gets to green. So this is how we are holding ourselves accountable to the performance so that we can get to the mission and vision and values and the strategic priorities of the healthcare district. And then finally, we do have a couple of senior leadership transitions. So Dr. Gabriel Cox, thank you for calling out Sherry. We have had some wonderful contributions from both Sherry and Allison. Allison continues to work with us in a consultant basis as she's back in her legal firm, and Sherry is going to continue on with us right up through new Chief Nursing Officer Phyllis Stark's start date on May 20th, and we'll continue to work with Phyllis for as long as Phyllis feels like she needs her for that handoff. So we have a really great smooth transition for all of this. We also have an interim human resources director, Margaret Morgan, who has a couple of decades worth of experience in a lot of the things that we're working on, and she'll be starting on May 8th. So we're looking forward to this senior leadership edition. That's all I have for today. Before I get to questions, I'm gonna let Matco give a few operational updates as well.
Thank you, Steve. Just a couple of things to touch on. Cardiac cath lab has been discussed previously. We did get our HCI substantial completion certificate, which allowed Tracy and her team to submit for our reactivation for our license for the cath lab. That was done on the 16th of April. We have an intensivist, a new intensivist that's going to be starting. Dr. Tony Medwar signed an agreement on April 9th. We expect that he'll be part of the rotation this coming month. Radiology agreement, we transitioned away from our radiology medical group as they're transitioning into their next endeavors. AVIS, Advanced Vascular and Interventional Specialist, started on April 15th. Dr. Kamal Singh is the primary on that group, and we're working with them to get them onboarded and integrated into our systems. Learning new PAC systems and everything else has been a little bit of a challenge, but we expect that that's going to smooth out over the next few days. And last but not least, we had talked about this previously at these meetings. Our pediatric stabilization program in conjunction with Santa Cruz County is moving along. We had our first Pacific Clinic staff, which is the contractors for Santa Cruz County, on board as part of our orientation this week. They will be starting and getting their program off the ground next week. Getting their system set up and everything in place to allow for us to have a go live mid-May. And we'll be doing a joint announcement with Santa Cruz County on that program, so look for that coming soon. Any questions?
Any questions for either Steve or for Metco?
To comment?
Yeah.
Some initial feedback about one of the new radiologists, Dr. Singh. A physician told me they were thrilled that they were willing to do a lung biopsy the following morning and things were, and that used to be a 5 or 6 day wait.
Yeah.
So, yeah.
We've been very successful with the procedures, and the interventional radiology component has been really good. We're working on getting the rest of it caught up, but from an IR standpoint, it's been a really good watch.
Thank you.
Any other questions? I have just one question for, I think it was on slide 7, Steve, about the survey. Do we break out the surveys by like demographics or anything like that? Or what, do we ask for that data, for that information when we're doing the survey?
The patient experience survey or the employee?
The patient experience survey.
Yeah, so I think I presented last month, a breakdown between, people who primarily speak English at
Yeah.
home versus people who primarily speak Spanish at home.
Mhm.
Those are our two main
Right.
groups, right? And there are other demographics that we can look at. We can look at male, female, we can look at age brackets, things like that. So if there's anything you're interested in, we can pull patient experience data by a number of different things, diagnosis codes. You know, you start to get different categories and you start to get really small sample sizes. So, and you gotta make the timeframes bigger and things like that. But yeah, there's definitely a lot of different ways you can break down the data.
I'm thinking of, and maybe this is just, something that you can send me, or, you know, the entire board. But the number of our patients that, speak indigenous languages that are filling out the surveys,
Yeah.
and just the number of that, you know, compared to the number of, people that speak indigenous languages that we're serving.
Right.
That would be great. And how do we?
I don't know that I've ever seen such a mixed echo on the coding of the patient experience data. I think they're usually either just checking Spanish or there's an other category.
Right.
So I think I've seen Chinese, I've seen Spanish, I've seen Portuguese, I've seen English. But I don't think I've ever seen any of the indigenous languages noted, probably because the HCAP survey doesn't recognize it.
I see.
It would be my guess. I don't know, Tracy's, you look like you were like ready to say something. You want to answer that?
Tracy, do you wanna? Yeah.
Well, we do not offer a mixed echo written survey,
Uh-huh.
and we did reach out to the language services that we work with, and according to the language services we work with, there isn't a
There's no.
written version of mixed
Right.
echo.
Right.
It's mainly a spoken dialect, so that's a real gap that I don't know how we're able to capture in our demographics that we do take in. They do write in other, and we can work to add a mixed echo category for our demographic intake to the hospital. But I don't know that we have that
surveys.
ability to do that because it's a third-party vendor.
Right. Okay, let's talk more about that.
Sounds good.
Yeah,
Yeah,
that'd be
thank
great.
you.
Thanks, Tracy. Any other questions? Okay, Steve, thanks for your report. Any public comment on Steve's report? Any online, Rosie?
No one's got straight online.
Any public comment from people? Tenants, no. So we don't need a motion on this, so we'll move on to item number 8, and that is the Chief Financial Officer Monthly Financial Performance Update. Julie, whenever you're ready.
I want to do it. That's it. I can do it. I mean, if it's easier, I can do it, especially if you're gonna take any notes.
Just give me one moment to share. Okay, we are ready.
Go straight to the first slide. Oh, wait, did I forget the, okay, this is Mark performance.
I figured.
Blew it right off. Okay, Mark, oh, hold on. I hope you have the right.
I do, but I'm not showing the right screen. Here, one moment.
Yeah. I don't know how. I figured it'd be around.
My PowerPoint crashed. Sorry.
Identify that.
I'm also thinking about.
Yes.
Right.
How do you know what it means?
No. But they get that. Virtual service. Or serving in there and do this language. Apply for that there. So that's the sort of stuff. So like.
I know.
So I'm happy to talk.
Yeah, let's do it.
Okay, so we do have March data here. And as Steve alluded to in the dashboard, we're at red, just slightly below on a year-to-date basis. And so I'm gonna take you first through March, the month, and then go into the year-to-date slide. So in March, the month, we had a net income loss of $773,000. Primarily, this was a challenge in the net revenue area. We were below budget by $2.4 million. We are doing a lot of deep dives into the AR valuation, accounts receivable valuation, and generally speaking, yeah, a lot of it has to do with sometimes payer mix shifts, service mix shifts, and just trying to ensure that we value things appropriately when we've done a price increase, which we did at the beginning of the year. So I'm not going to spend a lot of time on that tonight. Just know that we are continuing to dive into that. Currently, we are sitting within our budgeted kind of net revenue collectible percentage. But as you know, from the prior 2 months, we were looking more favorable than we had anticipated, and now it's kind of evening out. This month, we did recognize revenue for the Packard loan payment that we made in March. And so that had a value of $1.9 million that we bring into the net operating revenue numbers. We're doing well with our labor expense. We're, just I was a little bad today, about 550,000 or 6% below budget. Been a lot of work at the management team level on productivity and premium pays, overtime, double time, a lot more focus and visibility. And that's helping our salary expenses. Our supplies continue to be over budget. This month is not nearly as high over budget as they were the last couple months. We've been doing a deep dive into what work can be done with our group purchasing organization, and I think there's some new reporting and things now that there's enough of the system implemented so that we can identify opportunities and make adjustments to supplies to get a little bit more in line with where we expected that program to take us. And then we have some power optimization initiatives on the horizon in various departments. And then the last category of our quality assurance fees, which is in the other category. I think I mentioned this last month that the fees were approved after the budget was set. And so they are a little bit higher than what we had budgeted for. But the good news of that is that the revenues that we will get from those fees is also a little bit higher than we budgeted for. And finally, we include the MPT insurance. That's the hospital building insurance that we pay to MPT as our, since they hold the property right now. And we just have a little bit of a mismatch where we budgeted the expense below the EBITDA line, but we brought the expense up on an actual basis into the other line. So we'll see that mismatch this year, but it's on budget for what we budgeted. Next slide.
So here's what the year to date, so 3 months looks like. This is where we have the $3,500 miss as the net loss line. But you can see, again, it's really the same 3 categories that I just talked about on the month-to-date basis and the same storyline there. Next slide. The next couple slides talk a little bit about volume, and there's a couple of nice highlights here. The first one being admissions. Admissions were up to 294 in the month of March, and that's the highest number of admissions per day since September of 23. So it's nice to see a little bit of increase there in the admissions. And if you take out, February, which was a little bit lower, you can see, kind of a nice increase from October back up to March. Next slide. Here's what deliveries look like. We had a great delivery month, did 80 in the month of March. So the last time we did over 80 was back in August of 2023. So overall inpatient volume, our admissions, while we're below budget, they are higher than we were in prior year. And I'm kind of reading. You can do a little bit of it, but I can't read from here.
Okay.
Yeah, I'm okay. Yeah, thanks. Our case mix, or the acuity of our patients, is down a little bit lower than what we budgeted and down from prior year. So we're watching that as we see the types of services that we're offering. One of the things you see here is that we've had lower inpatient surgeries this month than the last couple months, and that's really would be one of the contributors to a lower case mix. And we're doing very well with our length of stay. Below, I think we're 3.59 this month. We budgeted about 3.8, and so that's very solid performance, meaning we're getting people the care they need and either discharged home or to their next level of care in a timely manner. And that is my driver towards the HACS healthcare acquired condition goal of Steve, because we know that the chances of getting a healthcare acquired condition can increase the longer you stay in the hospital. Next slide. Here's what outpatient visits look like. Got a little bit of my own slides here. So I can't just read my numbers at the bottom. So I broke this time down into visits per day, and the green is your ER visits per day, and your yellow is the non-ER visits. So we did about 96 ER visits a day, and we're doing about 110 other outpatient visits per day. And you can see, we've got a nice trajectory going up the last 4 months. And there is a bit of seasonality here that also sometimes follows the nice weather and the fact that people want to come to Santa Cruz in the summer. Next slide. Here's a look at surgeries. So I mentioned, the inpatient surgeries have been down a bit in the last couple months, but business has been booming on the outpatient surgery side. February, of course, was just phenomenal with 150. This month, we did 115 outpatient surgeries, and 19 of those were robot assisted. So it's nice to see that the robot assisted trend is staying up high in the area of 19 to 20 a month. A little further breakdown on the outpatient surgeries, and really the 3 main areas where the bulk of our surgeries, general surgery, orthopedics, and OBGYN. We're definitely beating kind of our monthly average from last year. And so far, just in the first quarter of the year, we've done 75 more outpatient surgeries than we had done this time last year. So that's impressive. Here's a little look at the payer mix. First, the inpatient payer mix based on admissions. This month, we saw a little stronger commercial mix at 14.3%. We're seeing about 50%, almost 51% in the managed government plans. That's your managed Medi-Cal, managed Medicare. and about 30% in the fee-for-service payers. And then we did have a little bit of an anomaly with self-pay this month, but this is actually related to kind of a glitch that happened with the transition of our national provider number. So this number will actually decrease. Most of those patients will end up with some sort of eligibility in Medi-Cal or the Alliance program. On the outpatient side, we also saw a little stronger commercial mix, 23% this month. And, you know, we're quickly approaching 50% of our outpatient visits being the Alliance. And actually in our ED, we had almost 57% of our ED patients this month were from the Alliance. You know, it's great to see the, you know, commercial mix improving a little bit here. And, you know, we have a very strong partnership with the Alliance. The one kind of cautionary tale about outpatient volume is that it pays at a lower percentage, overall collectible percentage than the inpatient. So some of this valuation that I talked about with the AR and how we're trying to value our AR and be as consistent, we're feeling the effects of getting a little bit stronger outpatient visit, volume than inpatient volume. That's it.
Thanks, Julie. Any questions before we open up to the public? No. Rosie, any raised hands online? No?
No, no,
Any comment on the report? No. I'll bring it back to us for any closing comments for Julie. No? Okay, so that brings it in. I'll call the Healthcare District Hospital Corporation meeting. I'll close that meeting.